Hello, my name is Vicki Hudson. Thank you for joining us for Module 2 of our educational program entitled The Thoracic Oncology Nurse Practitioner's Role in Patients Living with Small Cell Lung Cancer and Lambert-Eaton Myasthenic Syndrome. This program is sponsored by Catalyst Pharmaceuticals. Please see the Catalyst Pharmaceuticals disclosure statement. Within this second module, Beth Sandy, a nurse practitioner from the Abramson Cancer Center at the University of Pennsylvania, will explore what to do if you suspect LEMS and how best to conduct a differential diagnosis.
Thank you, Vicki. I'm glad to be here today. These are my disclosures. Let's talk about LEMS clinical presentation, and we'll start by talking about the neuromuscular symptoms, which are really what we usually will commonly see first. And the proximal muscle weakness occurs in almost all of the patients, in about 97% of patients, and that's definitely what I noticed first in the patient that I had, typically even in the hip area. And then distal leg muscle weakness occurs in about 31% of patients. Oculobulbar involvement occurs in about half of patients. The proximal weakness in the lower limbs can present as an abnormal gait, and that's frequently what we will see. This is a very specific gait that we will show a video that will illustrate that. The weak muscles often will ache and become tender for patients, and they can have difficulty standing up from a seated position, climbing stairs, or walking. There's also autonomic symptoms such as dry mouth, which is really frequent in about 83% of patients, orthostatic hypotension, constipation, and male impotence as well. So how do we recognize LEMS during a routine clinical visit? Well, the weakness is usually the first thing that we will see. And a lot of times, like I said earlier, it can be confused with symptoms of small cell lung cancer or side effects from the chemotherapy. The weakness in the lower limbs, though, may present as this abnormal gait, and that's really where we see a differential from just a typical fatigue that patients may have. Also, that standing up from a seated position is also something that's sort of different than what we would typically see with just a side effect of fatigue in a patient. So that abnormal gait, difficulty standing, those are things that we might pick up on a routine clinical visit. So what are our diagnostic approaches? Well, we would test for this anti-VGCC antibody, and that can confirm diagnosis. That would be a blood test, and or doing an electrodiagnostic test, which is a high-frequency repetitive nerve stimulation or post-exercise facilitation test. That can also be a confirmatory diagnosis tool. LEMS may be suspected based on clinical symptomatology and physical signs, but we really need to do one of these confirmatory tests to make a definitive diagnosis. So testing for the presence of this anti-VGCC antibody is supportive of a LEMS diagnosis. There's two different subtypes. We can see the PQ subtype in the predominant mediator of the neuromuscular transmission. And this type can be detected in about 90% of patients with LEMS. A less common type would be an antibody against the N subtype, and that can be detected in about 30% of LEMS patients. The N-type antibodies are often seen with LEMS associated with cancer. The PQ-type antibody are highly specific to LEMS, but have been reported in 1 to 4% of patients with small cell lung cancer, even without neurologic dysfunction. Sensitivity and specificity of the VGCC antibody tests may be affected by the source of the antigen and the specific laboratory performing the measurements and testing techniques utilized. So while a positive anti-VGCC test can support a LEMS diagnosis, it should be noted that a negative antibody test does not rule out a diagnosis of LEMS, and electrodiagnostic testing should be performed as a follow-up. So when we differentiate LEMS from small cell lung cancer with CNS involvement, so this is something also that came up in our conversation, Elizabeth. So approximately 80% of patients with small cell lung cancer will unfortunately develop brain metastases. And about 60 to 75% of patients with brain metastases present with neurologic symptoms. Even 10% might have seizures. So it's hard sometimes to differentiate here what could be from brain metastases versus LEMS diagnosis. I think one of the main differences here would be that gait abnormality and the ataxia, which is present in 15 to 20% of patients with brain mets, but really is indicative. Remember, it was like up to 90% of patients with LEMS. Also, with LEMS, we probably wouldn't see the nausea, vomiting, the headache as much. So the obvious, though, for me is that we would, do testing to see if there's brain mets there. And then when there is not brain metastases, then I would be looking more for something like a paraneoplastic neurologic syndrome, such as LEMS. The other thing that we see in small cell lung cancer is patients with leptomeningeal disease. Leptomeningeal disease is when there's circulating cancer cells within the meninges. And so with this, we frequently will see headaches, back pain, nausea, cranial nerve deficits. You can see gait abnormalities, but I wouldn't say that's one of the first things that I see in patients with leptomeningeal disease.
The NCCN guidelines for small cell lung cancer currently includes the recommendations listed on this slide. For patients with small cell lung cancer and symptoms that are indicative of Lambert-Eaton myasthenic syndrome, or LEMS, including proximal muscle weakness and autonomic dysfunction, a neurologic workup, preferably in consultation with a neurologist, is recommended. This workup may include, but may not be limited to, tests for PQ and N-type voltage-gated calcium channel, or VGCC, antibodies. Early subspecialty consultation should be considered for unusual paraneoplastic neurologic syndromes to ensure the most appropriate management is done.
So when we talk about nursing management, the recognition of the paraneoplastic neurologic syndrome by a multidisciplinary team will definitely be the best way to support our patients. Again, I am not working in neurology, I'm working in oncology. So I definitely would want to get these patients referred pretty quickly to neurology. We know that these LEMS symptoms can be really impactful for the patient's quality of life. So we want to make sure we're asking them about how much immobility are they having from it? Are they able to perform their own self-care? We need to make sure we consider their physical, psychological, social, spiritual, and other practice requirements that this could be affecting for patients. So really doing a full needs assessment is really important when we suspect or diagnose LEMS or any paraneoplastic neurologic syndrome. Making sure that we're referring to other healthcare professionals, maybe not only just neurology, but possibly things like physical therapy to help with other physical and practical capabilities that the patient may be suffering from.
Thank you, Beth. Recognizing the early signs of LEMS and understanding its implications are crucial for timely diagnosis and improved patient outcomes. As clinicians and healthcare professionals, staying vigilant allows us to better support our patients through earlier interventions. Thank you again for your attention and your commitment to advancing patient care.